All right. Hi, everybody. Thank you for joining us today. My name is Myra. I am the program manager for the Mid-Atlantic AETC here at WVU. Today, we are doing this session on state HIV prevention initiatives. Our speaker today is Nathan Kirk. Just a disclaimer before we get started, this project is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $3.2 million with 0% finance from non-governmental sources. The contents of this session are those of the author and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. The mission at the AETC is through comprehensive healthcare workforce education, clinical consultation, and technical assistance. The AETC program enhances the quality of HIV care outcomes for people with HIV and communities disproportionately impacted by HIV across the U.S. and its territories. Our vision is to transform HIV care by strengthening systems of education, consultation, and support, advancing a unified interdisciplinary workforce equipped to meet the evolving needs of patients and clinicians nationwide. Our speaker today has no disclosures. Nathan Kirk, who is our speaker today, is the director of the Division of STI, HIV, Hepatitis, and Tuberculosis within the West Virginia Department of Health's Office of Epidemiology and Prevention Services. In this role, he provides strategic leadership for statewide public health engagement, managing division operations, policy development, grant oversight, and program support. Nathan began his public health career in 2017 as a disease intervention specialist investigating complex HIV clusters and standard STI casework across West Virginia. He quickly advanced through leadership roles, serving as DIS supervisor and later as field operations manager. Throughout his tenure, he prioritized cross-program cohesion, modernizing training protocols, and mentorship for new DIS, emphasizing the importance of syphilis staging, partner services, and shoe leather epidemiology. Prior to entering public health, Nathan spent 13 years in behavioral health as an endorsed behavior support professional, delivering therapeutic consultation services for individuals with intellectual and developmental disabilities. This diverse background in clinical care and field operations directly informs his current administrative and leadership strategy. Okay, and I am going to stop sharing and hand things over to you, Nathan.
All right, well, thank you very much. Good afternoon, everyone. First of all, can everyone hear me okay? Just a thumbs up or just a reassuring nod
Sounds good.
will be good. All right, thank you, Kelly. Had a little bit of technical problems today and a few other meetings, so I'll take all of those thumbs up. I'm glad to see those. I did a quick scan of our participants in the call today, and before I get started, I just want to say hello to Annie Bayer. I think a lot of Annie. She's been doing this work a long time, and it's always a pleasure to see somebody I know in the chat. So and Myra as well. I appreciate the opportunity today. This is my first Project Echo opportunity that I've had to speak, and this slot was originally slated to be filled by our previous HIV prevention director. But I was really glad to have the opportunity to come in and sort of fill the spot this time. So I will talk a little bit. I have kind of a format that I do when I talk about a program here. So I like to talk about the background for HIV prevention, and I don't have any slides, so you just kind of get to look at my head floating in front of this blurry background of mine. But I'd like to talk a little bit about the history of HIV prevention programs, just very briefly. And sort of then I'll get into West Virginia's piece. So a little bit about the background of CDC-funded HIV prevention programs that'll all tie together nicely as I move through this. So the CDC and prevention started funding HIV prevention in the early 80s. It was initially surveillance and community education and targeted clinical testing, behavioral interventions. We have a lot of modern initiatives like ending the HIV epidemic in the US, the EHE. All that kind of started then. It was about 80% of funds were going to local health departments and organizations. That was back in the 80s. Moving forward through to today, talk a little bit about where we are now, and not just with West Virginia, but with our CDC-funded programs. So we are operating under a high-impact prevention grant from the CDC. Basically, there's been a few different approaches through this cycle that we have worked through in West Virginia over the past couple of years. Right now, our funding is through high impact HIV prevention and surveillance programs, and it's PS 240047. And one of the driving principles behind that is the uh, status neutral is a new thing that's sort of become fairly driving in the work that we do here. We strive for a status neutral um, for our folks that test with us. And if you are familiar with the status neutral model, it's I like it. I have a background in behavioral health. I feel like that whatever opportunity we have to provide a service to you, that's a good thing. You shouldn't really differentiate much when you have that opportunity. So um, essentially, give you kind of an overview. Status neutral mandates directly into primary, state, and local health department funding. That's for us. And that is our PS 24 grant. So talk a little bit more about PS 24 and how we utilize that here in a few minutes, but a little bit about state law. I would like everybody to take some time on. I won't go into it because it's quite lengthy about our state health code, but most in West Virginia's framework for HIV testing and prevention, it's primarily governed by the AIDS-related Medical Testing and Records Confidentiality Act, and that's West Virginia Code 16.3 Charlie-1, and that's where a lot of our law is here in West Virginia. If you want to explore the West Virginia Code Chapter 16, it's fairly encompassing of a lot of the work that we do here in my division. It talks state guidelines. If you get through it, basically it talks a lot about promoting routine opt-out screening, strict record confidentiality, and structured partner notification services. And we'll talk a little bit more about those partner notification services as we move into each branch of our prevention program here. So my division is the Division of STD, HIV, Hepatitis, and Tuberculosis, and it exists within the Office of Epidemiology and Prevention Services. Our HIV prevention piece of this division is actually sort of three prongs. There's three components to it. There's a field operations manager, which oversees the public health follow-up side, which is our disease intervention specialists and our prevention personnel. We have an epidemiologist who oversees our surveillance branch. And I'll talk a little bit about how those intermingle and work together as we move through this. And then I'll talk a little bit about the program specific things with our prevention. So the HIV prevention is a centralized personnel model. They're responsible for statewide travel. They do technical assistance for health departments and CBOs, community-based organizations. Where they also can offer technical assistance with community engagement, testing event coordination, educational presentations, and they also handle the procurement and inventory piece, which we'll talk about more closer to the end of this. But our prevention program here in West Virginia has undergone a few shifts in the last few years. And currently, we have some new personnel there. We have a few new positions, and we've got some long arching initiatives there that we're looking at. Talk a bit more about linkage and referral here in a moment. Our surveillance branch of this prevention piece, this all operates under PS 24. Our surveillance piece, they monitor and quantify HIV data through the Enhanced HIV/AIDS Reporting System. That's the EHARS system. One of the most, well, they do many things in surveillance, but probably the one I wanted to mention today was what is called time-space analysis. They routinely will do those. They set those up to run. And when we see an uptick in a disease, in HIV, for this particular surveillance piece, when we see an uptick in HIV, they will immediately convene with the HIV prevention and the disease intervention specialists pieces of the program. And each case will be analyzed to look for risk factors that complement each other or overlap in partners' name throughout the cases. So our surveillance is a big piece of this. And not every time, but often they will see something in the data that will trigger a public health action. A lot of times our disease intervention specialists will see the first uptick in a particular disease in their region. We'll talk a little bit more about that as we go. But that's our HIV surveillance and our prevention piece. There's the disease intervention specialist is the third branch of our program. And they are responsible for the most direct public health follow-up efforts for our individuals who are either contacts to a confirmed case of HIV or who are a newly diagnosed case of HIV. The disease intervention specialists here in West Virginia, they're stationed around the state. They're our largest outstation program. And they're a pretty good program, pretty good. In my intro, I was a DIS for a long time, and it was very rewarding work. So there's folks all around the state who do this work, and they do much of the same functions as our prevention personnel, but not as much capacity because they do have a caseload that they work. Disease intervention specialists in West Virginia, they are assigned cases of STDs as well as HIV, and I'll talk a little bit more about that and how that complements each other here in just a moment. So that's the three sort of branches of our prevention program, and they all function independently, but they also all work together to accomplish our prevention and public health follow-up efforts. So I talked a little bit earlier, I mentioned the status neutral foundation. That's our approach. The status neutral HIV model focuses on the person rather than the test result, and I mentioned earlier that's important to me. It uses the same entry points when available, when possible, and comprehensive care system for everybody. Those who test negative receive prevention tools like PrEP, realistic risk reduction plans. And while those who test positive, the faster we can get you over to ART, get you started on your antiretroviral therapy, the better. So try to get you to the status neutral. Everyone receives education about HIV, of course, with CDC approved materials, wherever you test, however you interact with us. The goal for prevention, make sure that we leave you with something. Our goal was to make sure that when you part ways with us, you're in a little bit better place than what you was maybe when we met you. It's a big deal to me. It's behavioral health background. I think everybody could use some help. So we look at syndemic coordination also. I mentioned our disease intervention specialists. They are also assigned cases of STDs, syphilis, chlamydia, gonorrhea. We focus on reproductive age females. And with some of our diseases, those will take priority. So they are assigned cases of that, and our disease intervention specialists have a reactor grid that they use to prioritize their cases. They work with HIV prevention in this as well because syndemic coordination, basically all the personnel who work at HIV prevention or the DIS branch, they are required to be able to link an individual to core services, which includes PrEP referrals. And I say referral, not linkage. There's a little differentiation there. True linkage to PrEP and navigation is a very real goal for me as a director. Looking forward at some personnel that I'm looking to bring on, there will be true PrEP navigation as a piece of the HIV prevention here in West Virginia. My goal would be to have someone within the program refer to someone else within the program to work with somebody on PrEP to navigate them through the portals, get them signed up for the discount card, get them on PrEP as soon as possible. It's a very real plan. I've got a great foundation for it. I'm working with another program here called the Ryan White Part B program, which I'm sure most folks are familiar with. That also is here with the Office of Epidemiology. And we're looking to make that happen sooner than later. So true PrEP navigation is just a goal for me as a director, and I think I can achieve it. So everybody that works here at HIV prevention or the DIS side, they need to be able to make that referral for PrEP. So you should be able to do that via a QR code that we maintain, or you should be able to bring up the National PrEP locator on your phone. You should be well versed in how to link someone with PrEP or refer someone to PrEP. Part of the metrics for the PS24 grant that we operate under, the CDC would like us to be able to quantify how far we can get somebody in the PrEP process. So ideally, I would like to be able to do from referral to linkage to the medical visit to the pharmacy pickup. I would like to be able to have someone do true medical case management with somebody until we get to that point. So that's a big goal for me. But we're not there yet. But we are at the referral step. So everybody within our HIV prevention program, we do have a QR code that we maintain, which has your most local PrEP provider. We went through the counties and tried to determine who our best bet was to refer people to. The DIS are located in regions around West Virginia. So there's a local contact list in the QR, and also, of course, the national PrEP locator. Let's see. So for services that are provided from the HIV prevention program, some of our most direct services that are beneficial to our communities are to be able to supply with supplies. So the rapid testing supplies that we're able to buy through our grant and through a block grant, we try to purchase, we try to strike a good balance between technology and availability and cost. Because we operate under federal dollars, we of course have to account for all of our money and do all the fun things at the end of the day, make sure our tally matches everything and return on investment and all of those fun things. So we try to strike a good balance between what we're able to track, what we can account for, and where it's going to do the most good in our communities. So there is a mechanism here built into the program where we can provide rapid testing supplies, rapid testing kits. A lot of times that would be RQuick, which is the oldest technology. On occasion, when we can provide Insti, we do that as well. And those are our two kits that we use here at the state level. We used a Lear determined for a little bit, but just because of purchasing and things, we use RQuick and Insti. Kelly?
Sorry, someone had asked if you can provide the PrEP QR code, whether you want to share that now or share it later, just so I don't forget.
Sure, absolutely. I can send that to you, probably be easier via email.
Yeah, that's fine. If you send that, I can send it in our recap.
That would be fantastic.
Thank you.
I just don't have it handy. I would have to dig for a moment, and I'll send it to you via email. So yes, the QR code is maintained here, and we update it fairly frequently. So another word about prevention here in West Virginia, our website is undergoing a major overhaul, complete restructure. The new pages are built. The old pages are still there for historical reference until we get all the information migrated over. Of course, everything we put on the website has to go through legal and comms. So it takes a minute to get everything up there, but ideally, once we get all that done, we will be able to have our QR code right there. So yes, I'll share that. So from the HIV prevention, basically from the ground level here, what can we do to help support our communities? The way we've managed to set this up in a workable structure for us so that we can monitor and account for inventories and do everything that we need to do under our grant requirements, we look to our local health departments throughout the state. So we have about 48, I think, around the state. Some health departments are rapid testing pretty aggressively. Some health departments are interested in it, but they don't have a lot of funding. We totally understand that. So what we have set up here within our program, we have a procurement and inventory personnel. We have someone dedicated to that so that we can meet our federal requirements and track all of our inventory, and also ensure that we can keep things in stock that our local health departments would benefit from. We have RQuick and Insti, and of course we have condoms, and occasionally we'll have other safe sex products. These are all things that we supply to our local health departments, and occasionally we have an abundance of these things, and we can work with community-based organizations. Community-based organizations are very important because we do have state guidelines and regulations about what we can purchase, and CBOs they don't really have those restrictions, so they can reach a broader audience sometimes. So if you have CBOs, they're a boon for sure. cut through a lot of red tape. So those supplies are purchased with funding provided in the grant, are subject to availability, but our program makes all reasonable efforts to fill all of the orders that we get. If we can't fill an order that we receive, we have personnel dedicated to work with the facility and let them know we wouldn't be able to fill that order, but we certainly could put you on the back order list. So there's a few stipulations with that. So again, to meet our federal funding requirements, we asked for our test forms. There's a standard routine test form it's a 1-for-1 match. The resource that we send you, the test kit we send you, you just simply mail back the form to our program so that we can put it into our reporting system and quantify all of our inventory and federal dollars spent. So I kind of went through a lot of things, a lot of different pieces here, and it may have been a bit incoherent, but I would open up the floor for any questions, and I would answer those as best that I can. Any particular area that I can speak on about any challenges we've had, anything that we've had to work through. If anyone in the audience today is also trying to figure out anything, I'd be glad to offer any insights that I have.
You had a question in the chat that said, for those who order test kits, how many can be dispensed to them at a time?
We typically will ship, if it's Quick, if that's what we have on hand, we typically will ship a box of 100. With those kits, we would send 100 pre-printed test forms, and we ask only that the facility return those test forms with us in accordance with West Virginia State Reportable Disease Law if you have a positive. All negatives, we ask that those forms be returned within 30 days of administering the test, and we ask for 100 forms back for 100 tests. Yeah. Any other questions about approaches? I'm trying to think of some useful things to the group. Some things that we've been working on. There is if anyone here in the group is interested in working with the West Virginia HIV prevention program, I'm going to drop a couple of email addresses in the chat. I'm, of course, a good contact, but we do have a program manager over there who would be more than happy to set up another meeting outside of this or whatever would be helpful to you. Like I said, with our community-based organizations, we try to be as selective as possible with who we can send test kits and things to. And we do traditionally try to make sure that we prioritize our health departments. A lot of people go there for screenings. And I mean, some of the things that our prevention and DIS do offer, one other thing is a counseling component. I didn't really emphasize technical assistance enough, but I mean, the program here in my division is always available for technical assistance. If someone is trying to work through anything or set something up in your community, we would love to talk with you and try to just give you information, try to help you bridge that gap. In West Virginia, we've worked many high-profile HIV clusters in the last several years. So, I mean, we've had to figure out a lot. We had CDC technical assistants come in, and they helped us quite a bit, and we definitely took away lessons learned. We've developed a lot of materials here, and we have been technical assistants for 5 other states. So we didn't just not learn anything. So, any other questions or anything I could sort of double down on or anything like that?
Hey Nathan, this is Trina Scott. How you doing today?
Hello, Trina Scott. I don't know where I know you from, but your name is remarkably familiar. Hello.
Well, I don't want to say who I work for, but I work for Gilead. But anyway.
Okay. Well, hello, Trina. Okay.
I wanted to ask, I know we had the PrEP was a pillar within the West Virginia elimination plan and wanted to see, is there an update on some of the successes that we've accomplished from that plan?
Yes. So our HIV elimination plan, the last version of this was a combination. It was a combination of viral hepatitis and HIV, and we had several work groups and several pillars. Yes, I was on some of those pillars. In my capacity as the director now, we're sort of coming into the end of that plan, but we will need to submit a new plan. And this coming cycle, this coming version of the plan, our viral hepatitis and HIV plans will be separate. But to answer your question, is there any updates, like any successes on that? We do have some updates. Yes, I don't have any of that in front of me, and I'm sorry about that. If I anticipated that question, I certainly would have. I do have the key public health, the KPIs. I do have those updated, and those, of course, will be published. We've had some favorable outcomes. The plan, in my opinion, was very very large. It was a big plan. There was a lot of moving parts in there, and I wasn't the director then, so I didn't have a lot of input on the structure. I was just in the work groups, kind of like yourself. But there are updates, and we absolutely plan to release those for sure. I mean, sorry, that's not a better answer.
No, that's great, and I appreciate that honesty and that I was on
Yeah,
that work group as well, and we had some good ideas and strategies. Just
I
want to see
agree.
some execution with it as well.
I agree. I like everything to be. Yeah, I know this is an aging term, but I like SMART goals. I like things where you time bind things, and you give
Yes.
that is how you actually get something done. And I know that's kind of that may be an aging philosophy, but most of the plan that will be implemented, they both plans still live in my division, so I've had input on both of those, and a lot of our goals will definitely be SMART goals. I would like to be able to give regular interval updates, but right now I pretty much am just sort of grabbing all of the work groups and getting all of the how did we do, looking at the KPIs, and just preparing an executive summary. But honestly, just from being on a couple of work groups that sort of had highs and lows, I mean, I actually looking at the KPIs, I wish it was better, but I mean, it's not terrible, and I look forward to making that available. As soon as leadership is ready to move forward on that.
Thank you, Nathan.
Absolutely. Anybody else? Nobody else. Well, I'm going to drop a couple of email addresses here in the chat, mine, and I'm going to drop in our other contact over here for our HIV prevention program. Like I said, we have individuals here who are dedicated just to procurement, and also to work with organizations that are interested in rapid testing. They have more guidance about what the requirements are for the program to establish rapid testing. I didn't really get into all of it today. It's a fairly lengthy PowerPoint, but it's not overly complicated. It's essentially just it's a two-way street to work with the HIV prevention program here at the state. We have to account for our supplies and things, public health landscape. Today, we account for everything. We make sure that we are good stewards of federal dollars. We are trying to meet all of our grant metrics so that our funding continues. And we have built mechanisms to do these things and still be able to provide supplies and technical assistance to anybody that we can work with, anybody wants to work with us. And again, about the disease intervention specialists, they are located all around the state of West Virginia, and they are another fantastic resource. They do wonderful work. And again, I'm not trying to be biased, but I spent a couple years doing that. So they are an excellent resource, and they are always willing to help. So my email address is in the chat, and a gal named Heather Hoffman's information is there in the chat as well. Do not hesitate to reach out to either one of us. If you want to set up a separate meeting, if you need any technical assistance, if you just want to talk a little bit more in a non-group setting, I will support all of that. And the prep QR code, I will send that to our host, Myra, and she should be able to distribute that on the meeting wrap.
And I'll be sure to include your emails as well for you and Heather, so everyone can have that as well.
Thank you, Kelly.
All right. Do we have any more questions, guys?